Okay, so today we will be discussing a 44-year-old man with weight loss, diarrhea, and abdominal pain, and this case is presented by me and Horace. Go ahead, Horace.
Hello everyone. So today we are presenting case number 3, 2020, a 44-year-old man with weight loss, diarrhea, and abdominal pain. So this patient was admitted for chief complaint of diarrhea, weight loss, and abdominal pain. And the onset was 3 weeks before 3 weeks after discharging from another hospital. He was evaluated for symptoms of fever, malaise, neck pain, photophobia, and retroorbital pain and headache. So 6 months before admission, the patient was having some early satiety, nausea, approximately 30 minutes after eating even a small amount of uh, food, and he had intermittent anorexia. He began to consume primarily liquids uh, for breakfast and lunch, and was skipping dinner. During the next 5 months, he lost 9 kg of weight. So, next slide. He had a medical history of depression, lumbar pain, uh, vitamin D deficiency, and no known drug allergies. Next slide. For family and social history, on social history, he used to consume a beer in a day and was not smoking, and sometimes occasionally he was smoking marijuana and was grown up in Caribbean. And for his family history, he had no family history of any kind of peptic ulcer diseases, pancreatitis, immune conditions, or malabsorption syndromes. And his mother had ovarian cancer. Next slide. So his chief complaint was diarrhea, weight loss, and abdominal pain, which he was admitted for. Next slide. On physical exam, uh, his temperature was for vitals. His temperature was 307 beats per minute. Blood pressure was 101 over 57 millimercury of millimeter mercury, and oxygen saturation was 99% on ambient air. His BMI is 18.6, and for physical exams of GI for abdominal physical examination, there was a notable and abdomen was soft and and there was no rashes, any kind of skin ulcerations or lymphadenopathy. And uh, on the labs, next slide. On the labs there was the per microliter, and mainly neutrophils were about 80, about 63%, and we have a monocyte elevation as well, and there's no other some significant values for a lumbar pain. puncture which he did, there was cloudy or RBCs per microliter, and and 1,000.
Hey Harris, can you turn off your camera? Maybe it will make.
WBC count per microliter in his CSF, and which was mainly most of it was neutrophils.
Just your camera, your connection is too slow. Sometimes it's interrupting your voice. So maybe you can turn off your camera, Harris.
Sure.
Harsh, do you want to quickly go over that one more time so we can, because it was hard to hear?
No, I quite well heard about red blood cells and white blood cells. So, but after that, it was sound was
so. So on his, okay, am I audible now? Hello.
Yes, we can hear you. Hello.
Harris has some problems with connection.
Okay.
Maybe somebody. Okay, go on, Harris.
Okay, so go over it again. So on labs, I said hello.
Yes, we hear you.
It just disappeared. I lost the connection. Okay. Okay. So was I lost the slides. Sorry. Okay. So was I audible for? Did you hear the explanation of the slide?
Yes.
Can you move on to another slide? So on labs and investigations, on urinalysis, it was all normal. On ECG reading, there was a right bundle branch block with no evidence of ischemia. And on CT of abdomen, there was a small diffuse mild distension of large and small bowel without any transition point. And
I think Harsh just lost internet. He's out of the meeting.
All right, guys. Well, I think you can catch up with this portion and continue.
Okay, so the urinalysis was normal. The ECG, it showed right bundle branch block with no evidence of ischemia. And on the CT of the abdomen, we saw diffuse mild distension of the large and small bowel without a transition point, so there was no indication of any bowel obstructions. So the tests for HIV type 1 and 2, treponema pallidum antibodies, Clostridium difficile antibodies, and IgA were all negative. And also the blood test for H. pylori IgG was positive. However, the stool test for H. pylori antigen was negative. All right, Jeff, if you want to take over.
So there was a couple differential categories that they were considering. The first one was cancer, And the first one was possibility of lymphoma. GI tract is the most common site of extranodal lymphoma, and it mostly involves the stomach. H. pylori infection can also contribute to lymphoma. Possibility of other small bowel lymphomas like Burkitt's lymphoma, B cell lymphoma, T cell lymphoma. These all present with like an obstruction or perforation or hemorrhage, and this was unlike the patient's bowel abnormality on presentation. Next slide. And then the second category of susceptible diseases was autoimmune disease. First one was celiac disease. This presents with symptoms of diarrhea and weight loss. Hypoalbuminemia also, which is present in the patient. Patient had negative transglutamase IgA test, but total IgA was not reported. You needed to rule out IgA deficiency in this disorder. This also causes neurological symptoms, but the case of meningitis seen in the patient rules out celiac disease because I think celiac disease is more ataxia seizures, things like that, not meningitis. Second disease was autoimmune enterotherapy. Diarrhea and weight loss is a characteristic of that disease. Lymphocytic immune reaction that causes enterocyte destruction and villus blunting, mimicking celiac disease. The presence of goblet cell antibodies is suggestive of this, but there was no causes of neurosymptoms. In eosinophilic gastroenteritis, this is eosinophilic infiltration of the mucosa and small bowel, which leads to nausea, diarrhea, and vomiting. There's peripheral eosinophilia, which occurs in patients, thickening of the gastric antrum and small bowel. And diagnosis is made by eosinophilic infiltration into the gut wall, which was obviously not seen in this patient. Next slide. And lastly, there was the category of infection. HIV associated infection was a possibility, but due to the mycobacterium avian complex, but the patient did undergo HIV testing and that came back negative. Whipple's disease was also considered. This is infiltration of foamy macrophages into the small bowel. The abdominal pain, diarrhea, malabsorption, joint pain, fever, CNS abnormalities. This is diagnosed via acid shift stain. Presence of joint symptoms and occurrence of meningitis are atypical with this disorder. And then finally, tropical sprue. This is due to the fact that the patient was from the Caribbean. It's a wasting diarrheal illness and uncharacterized intestinal infection leading to small bowel mucosal damage. Hypoalbuminemia is also present. Patient has mesenteric lymphadenopathy, which rules this out. And then Humza will present what exactly the patient had.
Okay, so first I just wanted to show this in endoscopic images. So in panel A, you see the stomach, and in panel B, you see the duodenum, and you can see diffuse edema and subepithelial hemorrhages, as well as diffuse edema and small erosion seen in the colon here. And the terminal ileum, we are able to notice a loss of villi, and that will lead me to my next point. So this patient is from a tropical region of the Caribbean, and there's a chance that he has an infection with Strongyloides stercoralis, which is a nematode and is endemic in tropical regions. And so the way that this parasite infects a person is that it first inoculates in the skin with a filariform larvae that lives in the soil. And so this larva migrates through the skin into the bloodstream and into the lungs. And then the organisms will penetrate the alveolar wall and ascend the bronchi and trachea until they're up in the pharynx, where they're then swallowed and can then rest in the proximal small bowel. And so that's how this patient started to display GI symptoms. And then these larvae will mature into the adult worms that inhibit the mucosa of the gut, where the eggs will be hatched into more larvae that are excreted in the stool. And this can last decades after initial entry, which is why the patient had initially immigrated from the Caribbean 10 years prior. However, his symptoms did not start till now. And also, I wanted to note the eosinophilic infiltrates, which is also known as Loeffler syndrome. And this is just the preparation of how the larva of this parasite looks like. All right, so the clinical presentation of this infection is common for epigastric pain, nausea, vomiting. All these will mimic peptic ulcer disease, as mentioned by Jeff, and watery diarrhea associated with the malabsorption of fat and vitamin B12, which also mimics celiac sprue and tropical sprue, also mentioned by Jeff previously. There's also a protein-losing enteropathy, hypoalbuminemia, and peripheral edema. And so this patient is from the Caribbean, like I said. He has a subacute wasting illness with abdominal pain, diarrhea, hypoalbuminemia. He has diffuse bowel abnormality on imaging and mild intermittent eosinophilia, while also having evidence of an episode of bacterial meningitis. And I also wanted to explain these specimens. So the duodenal biopsy image in panel A shows the crypt epithelium. The ova, the arrows pointing to the ova and the larva and the worms. And so this just shows how it can start as an egg and develop into the worms and cause infection over long periods of time. Okay, so this patient was highly susceptible to this sort of infection from this parasite because he has evidence of having a hyperinfection syndrome. This is due to his HTLV1 infection, which can cause immunosuppression and which can increase the severity and likelihood of getting this infection with this parasite. And this can lead to even more invasiveness tendencies of the nematode, which can penetrate the bowel mucosa and can lead to even bloody stools as well as watery stools. And these worms can actually carry gram-negative bacteria, which can lead to bacteremia or meningitis. All right. So the diagnosis of this patient was strongyloidiasis with human T lymphotrophic virus type 1 infection. And like I mentioned before, it's the patient's status, immune status is already being compromised by his infection of HTLV1. And so the transient episodes of his hemoptysis are consistent with the pulmonary phase of the autoinfection. However, the CT doesn't support the hypothesis that the eosinophilic infiltrates that are associated with the parasite infection are transient, and all of the other features of this patient's presentation are consistent with this diagnosis. I also want to mention that the patient was briefly given a glucocorticoid, and this can also increase the immunosuppression of the patient and increase the severity of the infection. So the peripheral blood smear of the patient shows mononuclear HTLV infected patients produced more gamma interferon and lower amounts of IgE, and that will lead to the increased susceptibility of a parasitic infection, because as we know, eosinophilia and IgE are related, and parasitic infections can be very severe if there's low amounts of IgE circulating and fighting against it. So because this condition is rare and it's not commonly seen, there aren't many studies available regarding treatment. However, the CDC recommends ivermectin for uncomplicated infections. And if the symptoms are persistent, then we would need to suspect the failure of the treatment and look at other possible interventions. So with those patients with the compromised immunity like this one with the HTLV1 infection, we need to continue to monitor them to make sure that the treatment is working still and that they aren't getting worse. So in this case, the patient was treated with ivermectin for 14 days, and it was followed by tapering the doses every 2 weeks for a month. And then he also continued the treatment because of his HTLV1 infection, and so just to decrease the chances of reinfection. And so this patient's presentation is more typical of a hyperinfection with a single organ intestinal disease rather than a classical disseminated presentation of spondyloiditis, which is usually a multi-organ dysfunction. So it's not as serious as we had previously suspected. So according to his resolution, the serial stool sip examination was normal. The GI symptoms were resolved, and he gained 23 kilograms over the months after the treatment. And the summary is horse here. Yeah.
Yeah. So summary of the case: we had a 44-year-old man and admitted to the hospital. Patient had no any kind of relevant medical history, but grown up in Caribbean. His onset of symptoms was occurred 3 weeks after he was discharged from the other hospital. He was admitted to lumbar puncture, um, and they did the ground staining of CSF, which revealed no organisms. They did CT, and which was no signification, any kind of signification in cities, and uh, they did PCR of the CSF, which was for herpes simplex virus type 1 and 2, which was negative, and mm, they came up with the differentials of cancer to immune disease and various infections, uh, which was ruled out, and the final diagnosis was strongyloidosis tuberculosis, which is a nematode from the Caribbean, and present with abdominal pain, nausea, vomiting, and watery diarrhea as symptoms. And the patient was treated with ivermectin.
Right. Thank you.
That's it.
Please keep the slides. Okay?
Yep.
All right, guys. Thank you very much. So it was very interesting case, and you know what? Actually, when I reading those cases and watching your presentations, I'm actually preparing new questions for your exams based on those cases. So I would like to go to the lab values slides, which were presented by Harris. And I would like to ask my classical question. What kind of anemia do you think this patient has based on the studies of the hemoglobin, hematocrit, iron, total iron binding capacity, ferritin? So what would be your possible kind of suggestion about the type of anemia this patient has?
Uh,
I'm sure you analyzed
Maybe
this.
megaloblastic, because so we have slightly decreased hematocrit and hemoglobin level,
Mhm.
not too much, but slightly decreased. And then we have uh, iron, we have slightly decreased.
Mhm. And then metaloplastic B12 deficient anemia, iron is decreased or normal in the blood. What do you think?
Iron, I think it's decreasing.
Why? What is the rationale for this?
Uh, Maybe hemolytic anemia.
In hemolytic anemia, what would be level of total iron binding capacity, ferritin? So we just discussed this in the reviews, guys. And what you see, guys, here, weaknesses where you need to practice a little bit your diagnostic skills. So to remember, you look always first of all on the iron concentration in the plasma. So in this patient, iron is what, 37, right? And on administration to hospital, 105, right? So it looks like 3 weeks after being in the hospital, the iron concentration is quite low, right? So it's on the lower border of the iron. So total iron binding capacity is decreased also in this patient. So and when you look also at the ferritin level is actually normal, right? So within the normal range. When you see a normal ferritin level, you cannot say that this is anemia of chronic disease, because in anemia of chronic disease, ferritin level should be increased. So total iron binding capacity decreased. It's usually indeed what in hemolytic anemias, right? Or some kind of anemias like megaloblastic anemia also could be total iron binding capacity decreased because of increased release of iron. So at the same time, when you look at the iron level, reference range is for this hospital 30 to 160 or 45 to 160. So then you look at it, it's also kind of low, but it's within the normal range, right? Iron. So it's really hard to say. It could be iron deficient anemia or what, like you said, B12 deficient anemia, but it's definitely not classical hemolytic anemia because ferritin level is 82. 82 is too low for classical hemolytic anemia like thalassemia or sickle cell disease. So it's either iron deficiency, right, or a combination of iron deficiency, B12 deficiency. Unfortunately, we cannot tell exactly here because there is no mean cell volume MCV data and the red blood cell distribution width. So to make final diagnosis. But I like how you were thinking. So B12 is very likely. Iron deficient also could be mixed type of anemia. Second question, guys, to your group. And now I ask Haris to mute his microphone so not to create background noise. Question to the second presenter. And the question is like this: why there is a rise in white blood cell count in the lab values? So, and which white blood cell types were significantly elevated in this patient? So, please.
White blood cell count was elevated because he was diagnosed with an infection. And what was elevated? I'm pretty sure his neutrophil count was elevated.
Neutrophils. Neutrophils were, let's say, 53, normal 40 to 70, so we're not elevated neutrophils. So it's not because of neutrophils. So what was actually elevated?
The monocytes.
Monocytes was 12.4. Yes, monocytes were increased. Very good. Anything else was increased in the hospital, particularly when he was already hospitalized? So look, pay attention to eosinophils, guys, right? So 9.8. So remember, this is really high level of eosinophils. So eosinophils at maximum should be no 6, no maybe 8, but it's like 9. It's really high. So eosinophils, so we could suspect actually infestation with some parasites in this case. Okay, very good, very good. So the answer is eosinophils, immature granulocytes were increased level, at least in the hospital, right? And monocytes, you said, absolutely right. Now, the next question for you guys is pharmacological. The mechanism of action, ivermectin.
Okay, so ivermectin, it mechanism is that it destabilizes the IMP alpha beta complex, and this is for the entry into the cells. So that will disrupt the.
Ivermectin can be used only for treatment of strongyloidosis, or there are some other parasitic infections we can treat with?
No, it's used. It's more wide spectrum.
You can use it for like scabies also.
Right.
Any skin parasite.
What else? What else besides scabies?
Lice.
Lice. Okay, so it's insects, right? Infestation with insects.
Yeah, like external parasites.
Threadworms.
And out of the worms, what kind of worms sensitive to ivermectin besides strongyloides? Oh, flat worms, round worms, which one?
It's most of them except tapeworms.
Can you say it louder? I couldn't hear.
I said most worms besides tapeworms.
Okay, so most roundworms except tapeworms. Okay,
Right.
Wonderful. That's correct answer. Absolutely right. So ivermectin is a wide, broad range medication. We give it with patients with ascaridosis, and we give it also patients with, let's say, pinworm infection. So there's many roundworms which are affecting GI and other systems like urinary system, biliary tract. Now, one more question, guys, to you is, why do you think of this patient had a low level of iron in the blood? So let's say it's always in his labs 37, 36, on the lowest range of the kind of, let's say, normal range. So why is it such low level of iron in this male? This is male, right?
Right. I think it's because he had a lot of wasting and cachexia, so this can cause a low iron count and weakness.
So what do you think? In which part of the body, or what part of the gastrointestinal tract, most of the iron is absorbed? No, to entire group, to entire your presentation group question is. So that's probably one of the questions on your final exam will be. So
it's more in the duodenum.
Very good. So more likely it's duodenum. Absolutely right. So duodenum is one of the major places for iron absorption. So can you tell me what's going on with duodenum in these patients based on the gastroscopy?
Right. So like I said in the let me bring that back up. So if you see the panel B, there's diffuse edema and subepithelial hemorrhages in the duodenum. That's a major reason for low iron.
Did we study also jejunum of this patient or ileum?
Yes, in the panel D, you could see the terminal ileum, and there's a loss of villi, so that can also be a major reason why there's a lack of absorption.
Good. So in ileum, what is most likely absorbed? What kind of substance is absorbed in the ileum, especially terminal portion? So which are really important to remember for STEP exam.
Vitamin B12. And
very good. What else? Very good. Very good. Bile acids. Okay. So very good. Bile acids. So theoretically, this patient probably at the risk of developing also of biliary stones, because bile acids not reabsorbed properly. So, and that's why I like also the idea of Harris that he may have megaloblastic anemia, because terminal ileum is affected. So probably B12 absorption is affected. Duodenum is damaged, so absorption of iron in duodenum is also affected. So that makes sense. All results will be what? Combination of iron and B12 deficient anemia with very strange looking values on the serum, iron, ferritin, and so on. So that's understandable. I hope for you guys that indeed sometimes patients may have more than one type of anemia. Because on step 1, you will be tested only on one type of anemia. not mixtures, because mixtures very confusing. It's usually step 3. All right, and one more thing. Let's ask question from the group number 4. Why there was eosinophilia in this patient?
Because it was a parasitic infection.
Because yeah, parasitic infection.
What other causes of eosinophilia could be? Let's say if you will have to think about differential diagnosis besides parasitic infection, what else can cause eosinophilia?
Allergies,
Allergies, very good.
asthma,
Mm-hmm.
cancer, Crohn's disease.
Crohn's disease, not sure, but maybe. What kind of hematological tumors or malignancies associated with eosinophilia?
Acute myelogenous leukemia.
No, acute myelogenous leukemia, usually eosinophils level is very low.
Oh.
So maybe if you change word acute to
Chronic.
yes, absolutely right. So the chronic myelogenous leukemia frequently associated with eosinophilia. Absolutely right. And last question for you guys is why he develops strongyloidosis? Is it normal for kind of middle-aged male to develop strongyloidosis? Is it?
So he actually was from the Caribbean, and strongyloidosis is endemic in tropical regions. So even though he had immigrated 10 years before, like I explained the infection, I can go back.
So you want to say that every male in Caribbean tropicals will develop strongyloidosis if will walk with bare feet on the soil?
No, it's very rare still, but if they do get infected and the larva does mature inside the intestines, because it has a long process just to get into the inoculated into the body. So if it does, it can persist and then last decades after it initially enters the body. So when he developed the HTLV-1 infection, it increased the severity of his strongyloiditis latent.
How? Oh, very good. So HTLV-1 infection. So he probably has immunosuppression caused by HTLV-1 virus infection. By the way, did he experience how they diagnose HTLV-1 infection in this patient?
Oh, in this patient, we had a. I'm sorry, I had. Okay, so the studies indicate that a peripheral mononuclear cells of the patient, it showed the presence of a HTLV-1 infection.
So that was a blood smear changes. Okay.
Right.
All right. Thank you very much. That's all from my side. Great job with answering questions. I understand. So there's some questions were quite tricky, but you did it to your best ability. All right, guys. Thank you very much. And